Joyce Troxler. I'm your facilitator for today. And my background is in family medicine and addiction medicine. And we're just going to go around and get everyone introduced. I don't know if this is maybe the first week of some summer break type activities and everyone but us is on vacation because we have a smaller than usual number, but maybe some more people will join us as we go. But in the interest of time, we're going to start with Meredith. If you can unmute and introduce, please.
Hi, my name is Meredith Ginley. I'm an assistant professor in the Department of Psychology at ETSU.
Great. It's good to have you, Meredith. Cameron, in the room with me. If you can introduce, please.
Cameron Hayel. I'm Associate Program Director here and also Associate Professor in ETSU. I'm a psychiatrist and addictionologist.
Great. Thank you, Cameron. Brian, if you can unmute and introduce.
Hi, I'm Brian. I'm the technology coordinator at ETSU CME. If you have any technology issues, you can send me a chat or call the number on your screen.
Thank you, Brian. Rick, if you can introduce for us, please.
Oh, hello, everybody. I'm Rick Wallace, and I'm the medical librarian at the College of Medicine at ETSU.
Thank you, Rick, for being with us. Skylar, if you can unmute and introduce, please.
Hey, this is Skylar Geller. I'm an addiction medicine fellow at ETSU.
Great. Thank you, Skylar. Dottie, if you can unmute and introduce, please.
Hi, folks. I'm Dottie Green. I am an associate professor in the Department of Social Work and the coordinator for the Clinical Addiction Counseling Studies program.
Great. Thank you so much, Dottie. Tanya, if you can unmute and introduce, please.
Hi, I'm Tanya Milam. I am the medical assistant working with the Addiction Medicine Fellowship here at ETSU.
Great. Thank you, Tanya. Michael, if you can unmute and introduce, please.
I'm Michael Mishka. I'm with TenCare. I'm a clinical director for behavioral health operations and a psychologist.
Great. Thank you, Michael. Veronica, if you can unmute and introduce.
Hi, my name is Veronica. I'm the Bachelor's of Social Work here at ETSU, and I am also the Certified Peer Recovery Specialist.
Great. Thank you, ma'am. Simona, since you find that you just got yourself joined by audio unmuted, if you can unmute and introduce, please.
Hi, I'm Simona. I'm one of the addiction medicine fellows here at ETSU.
Great. Thank you, Simona. Looks like Judy's still connecting to audio. Kelsey, if you can unmute and introduce, please.
Sure. Hi, I'm Kelsey Wallace. I'm a nurse practitioner and I'm the soon-to-be psych nurse practitioner student at UT.
Fabulous. It's good to have you with us, Kelsey. Judy was getting logged in, but she popped away for just a minute. So hopefully she gets connected to us. We can have her unmute and introduce. And then just as people join us at appropriate intervals, I'll stop and have them introduce themselves to us. So today I am your speaker, and I don't remember, I think in the reminder invite that went out, it was substance use disorder and transgender care. I actually gave a talk for the transgender conference that happened earlier this month, and I took that lecture and retooled it a little bit and actually boiled it down more to talking about, especially with our time limitation, more on infectious disease syndemics associated with substance use disorder. So that's what I'm going to be talking about today. I am not aware of a case being submitted for today. Brian, unless I'm incorrect, have we had one come in for this week? I don't think we have. Okay. Okay. So that means from our wonderful participants joining us today, be thinking about a case. It could be something that you have presented on before, or that you have a follow-up on, or it could be something brand new, something you saw this week, something you saw a year ago. Just by participating with what we're doing or having come into contact with other people, other ideas, you have questions, opportunities to expand our understanding. So we're looking for cases. Anybody who has updates, something brand new, or just general curiosities. And we can even just have a nice forum of sharing experiences, including successes with patients, because it's always great to hear about those. So be thinking about that while I am presenting on syndemics and substance use disorder. Jack, since you've joined us before I started giving my presentation, I'll have you unmute and introduce, please.
Hey, everybody, I'm Jack Larson. I'm one of the second-year residents at ETSU Family Medicine in Kingsport. Thank you, Brian, for getting me in.
Beautiful. It's good to have you with us, Jack. It's good to have all of you with us. So without further ado, I'm going to try and share my screen and get this going. Wish me luck. Really didn't mean quite job. Okay, you guys seeing a big screen with some feathers on it? That's what that is. Okay, cool. All right, so Syndemics of substance use disorder, HIV, and hepatitis C, presented by me, but you already know me, but that's who I am down there in the corner. So our objectives today, noting that stigma is a single risk factor that crosses many domains. Syndemic, recognizing that this syndemic exists so that one can address the co-occurrences of substance use disorder and infectious disease risk, and then develop an approach to address the syndemic. So one is knowing that it exists, and two is what do you want to do about it? So we'll talk about that a bit today as well. Stigma is its own beast in and of itself. Stigmatizing behaviors by others inflicted upon us definitely has impacts on how we see ourselves, how we function in the world, and risks that we may take on independently from that. I think we're all very familiar with adverse childhood experiences and the traumas that one experiences related out of that. It doesn't have to be just complete direct physical trauma that one is experiencing, but even things such as an unstable, uncertain home life where there's divorce, or someone in the home has a mental health disease, or someone has gone to jail, or there's a parent with a substance use disorder. Early adversity has lasting impacts, and it puts us at risk for things that's kind of the little lollipops off of the big purple circle. We see increased issues and concerns and less than anticipated outcomes for things like educational opportunities, income, increased risky behaviors related to alcohol, drug use, unsafe sex practices, chronic disease, where we see increased incidence of COPD, diabetes, hypertension, infectious disease, issues related to maternal health, mental health, and physical injury. So this is a kind of a pull out of a really nice, so ACEs, this is an ACEs questionnaire, but this is specifically targeted towards teens, adolescents completing their own ACEs questionnaire. And what I really like about this is you aren't marking which of these things did I experience, especially for a pediatric patient. Just recognizing that ACEs exist for this child is important. So you could just be like, yep, nope, yep, nope. And you just put how many of the yaps, total those up and put them in the box in the top. But as we all know, I mean, just even having the ACEs and recognizing trauma and the impact that it has been groundbreaking for so many people, and understanding their life experience. And for those of us caring for patients who've experienced trauma, which is essentially all of our patients, just even recognizing that as a factor is important. But I think we all realize that the ACEs don't get at everything that people may experience that can result in shorter life expectancy, increase in risky behaviors, that type of thing. So what I really like about this ACEs questionnaire, it comes from the Center for Youth Wellness, is there's a second section. Things like harassment or bullying, someone who is, like, you may have had a great home life until a parent or guardian passed away, and then like everything changed. So recognizing some of the other traumatizing things that could have happened in your life beyond just the typical 10 that we ask in the ACEs questionnaire that kind of kicked all of this trauma-informed care recognition out there. One of the things, and this is kind of a holdover slide from when I did the transgender care conference, sexual orientation, place of birth, disability, religion. So even a lot of what we've been hearing over the last year as well, along with our pandemic, is micro-traumas is a term that's come up, but just recognizing the fact that people of different races, sexual orientation, places of birth, disabilities and religion they are facing discrimination and stigma. So growing up in a situation where just because I am who I am, I'm treated differently than the others around me who are not like me. So again, stigma is a beast in and of itself, and recognizing its presence so we can be aware of that and help our patients transcend that trauma that they've experienced. So addressing the syndemic. So these are just fun slides demonstrating kind of where we are in the world with some of our sexually transmitted infections. HIV diagnoses, this is 2000, it says off the side, 2018 for some, 2000 for most of them, 2019 for tuberculosis. So HIV diagnoses have actually been somewhat on the decline. Hepatitis C has been on the increase. Hepatitis B has been slightly on the decline. Hepatitis A up, syphilis, chlamydia, and gonorrhea up, and tuberculosis down. I included specifically for Tennessee these numbers as well, and they're pretty similar to the United States, except for in Tennessee, our HIV diagnoses were on the increase. So great things are happening with what we can do as far as treatment for hepatitis, for HIV. But it's not going away, and if anything, it's increasing in our state. So being aware of, if you haven't made a diagnosis yet of HIV in a patient, a new diagnosis, you have a really good likelihood of doing so. HIV diagnoses actually in 2020, so a bit more current data in those ages 13 and older. This is United States data, majority male, but a fairly good number of females, and this is just those who have injection drug use. So this is kind of pulling data together out of the CDC, those who are 13 and older in the year 2020, diagnosed new HIV, not separating down for African Americans, Hispanics, Caucasian, none of that, just all races, all comers, both male and female, but specifically these individuals do engage in injection drug use. That's kind of the numbers that we're seeing for new diagnoses. This is just a slide that lets you know that some of the graphs that I'm showing you are ones that I pulled out. So I selected for those certain factors, like I want all genders, I want all races, but I want to see what it is in the United States for those who use IV drugs. And that data was not available for the state of Tennessee. We didn't have it for Tennessee. So knowing that HIV is on the rise in Tennessee, and for those patients that we care for with substance use disorder, and seeing those numbers for 2020 with IV drug use and HIV diagnoses, talking to our patients who might be using needles about how to keep themselves safe from HIV is an important conversation to be having, assessing them for their risk factors, and then talking to them about, and this is something we can do to help keep you safe. So pre-exposure prophylaxis for those who are at risk from either sex or IV drug use. This is something they can take on a daily basis to decrease the likelihood of contracting HIV. And then there's also the post-exposure prophylaxis. So something's happened, someone maybe who hasn't had any needle use in years, but had a one-time return to use, or there was a weekend, things happened, and they come to you on Monday after last use on Sunday, and they tell you, like, I've had some needle use and I'm concerned about risk, you could consider post-exposure prophylaxis for them, but we want to catch them within 72 hours after possible recent exposure to HIV. PrEP is highly effective for preventing HIV, reduces the risk of getting HIV from sex by about 99% when people take it as prescribed. We don't have as much information about effectiveness for those who inject drugs, but overall numbers are about 74% reduction in getting HIV when taken as prescribed. As with most medications, it is much less effective if we don't take it as prescribed. There are two different medications that we use for PrEP. Both of them are a combination and basically the same medication. And I did not drill down into why one versus the other. There are two different medications, Truvada and Descovy. I'm not going to attempt to say their generic names, but there they are for those of you who prefer generic names. So when you're assessing whether or not PrEP is appropriate for your patient, one is getting a history and knowing what are our risk factors, and are you someone who is in a risk category that would say, yeah, you need to consider PrEP for this individual. So pretty much bottom line, bare minimum, you need a negative antibody test for HIV before starting PrEP. There are other labs that you can get, and I've got some slides on that, but bare minimum, you want to get that negative HIV antibody test on the chart. One of the things too with this 2-drug combo for use in PrEP, it's not effective for treating HIV. So you want to be very careful about your education to patients about how they're using it, their consistency of using it, because if you have a patient who's using some, not always, they take it these days, but not those days, and then they do actually go on and contract HIV, there's a potential that you may have some viral resistance to one or both drugs. So that's part of the education you want to give patients when you're initiating them on PrEP. So other labs that you can get just to kind of broaden out your workup and evaluation before putting them on PrEP, serum creatinine and checking their clearance. Renal function is a concern with using the combination medications for PrEP. So you need to know that, but it's one of those things like, all I've got right now is an HIV negative antibody test. They're very high risk. I need to get these labs. I have to send them off and wait. So I'm just going to go ahead and start PrEP, and I'll make certain I get those labs at another time. And if it's inappropriate because they have a creatinine clearance of 45, then I just won't write anymore. Hepatitis B status needs to be known. Hepatitis B can be suppressed. So if they have hepatitis B, and you don't know it, and you put them on PrEP, and when you discontinue it, they can have a hepatic flare. So they could go from this kind of like smoldering hepatitis B presence to we have a hepatic flare, which we don't want to have. So knowing that they have hepatitis B doesn't mean that they can't be on PrEP. They can. But you may also want to go ahead and get them treated for hepatitis B while you're also prescribing them the preventive protective medication against HIV. So it's not a no-go if someone does have hepatitis B, you just want to know it to prepare for the potential of a hepatic flare if they were to stop the PrEP abruptly, but also getting them connected to treatment for their hepatitis B. So you got to take it every day. It's not going to help against any other STIs. You need it to be effective for 3 weeks in preventing HIV. So your patients, it's not like I took PrEP the first time today and I can just go do whatever and be protected against HIV. It's not going to work. They need at least 3 weeks. Maximum at a one time, especially when you're initiating, would be 90 days. I would like to see people back in about a month after starting just to make certain they're not having side effects. But depending on access issues or any of that kind of thing, you don't need to dole this out in small doses. You can be generous with your prescriptions, but you do want to get them back because you need to repeat HIV testing, just knowing it may be some time before someone seroconverts and is positive. Gives you a chance to document again that they remain uninfected with HIV, making certain that if risk factors haven't changed, that they still need to continue on the PrEP, because if risk factors change and they aren't there anymore, then the potential of coming off PrEP is certainly there. Make certain they don't have any side effects. Are they having any other concerns or questions about STIs? And then counseling and support to make certain that they keep taking the medication and they understand the importance of taking the medication. And then also opportunities to discuss behavioral risk reduction, because again, you're engaging with them, you're talking to them about their medication, knowing that those frequent contacts with you will deepen that relationship you have with your patient, and you may find that they start making their way towards some change behavior and decrease their risky activities as a result of the care you're providing them. This is a slide that just gives a rundown for you to look at later. I'm not saying all these words, don't worry, on assessing risk and determining whether PrEP is appropriate. So men who have sex with men who have an HIV positive sexual partner, definitely at high risk of contracting HIV, 100% a candidate for PrEP. Someone who is an injection drug user and shares equipment, definitely at high risk and definitely a candidate for PrEP. So this just is a really quick slide to look at. Do I have a patient who is in a risk category? Are they clinically eligible? What other services do I need to think about for this individual? This is hepatitis C. So moving from HIV into hepatitis C, just sort of demonstrating that we have an issue with hepatitis C. From the very beginning of slides that we were looking at, that sort of demonstrated from the CDC, like what different STIs, infectious disease type things, tuberculosis, hepatitis A, B, HIV, all those good things, gonorrhea, chlamydia. Tennessee and the United States, acute active hepatitis C is on the rise in both of those locations. So just some fun graphs to look at that all of them demonstrate we have a number of people with hepatitis C. There is an acronym that I always screw up, United States Health Prevention Task Force, USPFTF. Oh, I always screw that one up. One of the recommendations is kind of that baby boomer age group. They just universally should all be tested. We're moving to a place where everybody needs to be tested for hepatitis C. And you can see from the one bar graph that I'm showing you guys here, the most prominent age group is 25 to 34. And that's also a pretty prevalent age group that we're seeing in our substance use disorder clinics as well and treatment centers. So they all need to be screened for hepatitis C. So intake labs, like for our clinic and our addiction medicine clinic, when we have a new patient and they come to see us, we have a panel of intake labs that includes HIV as well as hepatitis A, B, and C. That basically tells us whether someone has hepatitis C antibodies. If those antibodies are present, it kicks us into a whole other line of thinking. Number one is we got to check a viral load. A number of people will clear hepatitis C and they don't need treatment. So if you have positive antibodies, negative viral load, you do not need treatment. I cannot tell you how many times I see people referred to GI for positive antibodies and negative viral load, to the point I have to stop and check myself and be like, has the evidence changed? Are we doing something different? Truth of it is, if you have no viral load, you have no virus to treat, you don't send those people to GI to get hepatitis C treatment. So I'm saying that to people I'm certain who know that, but I've seen it so many times, I have to go back and double check myself that that's still the truth. It's still the truth. But if you do come back with a positive viral load, you're going to want to get this next set of labs. Genotype, because we kind of got to know which one we're working with. The medications that we have available now pretty much treat all genotypes of hepatitis C, but in the event that your patient comes back and has been reinfected, very uncommon, probably not going to see it. You count it on one hand when you do see it. But you can demonstrate, was this a treatment failure or was this more of a new infection with a different strain? So if you know the genotype, the first time somebody comes back, are they reinfected? Oh yeah, I had 1A and now I have genotype 2. Like this is different, totally different. You want to know a CBC. Part of that is because some of the other labs you're going to get as you start into treatment, you need to see their platelet count because that factors into determining what type of liver function they have. But it also gives you an idea of anemia. So those iron studies come in. Some of the medications, one of their side effects is anemia. So if you're already starting with an anemic patient and you're going to put them on a medication that has a side effect of anemia, you can work to beef that up and get them in good shape before you start treatment. As far as their ferritin level, and making certain that they're not anemic. CMP, because we need those liver enzymes. It's also good to know their renal function. And then PT-INR, that just again gets at liver function, because if we have a cirrhotic liver, we're not making all those coagulation factors the way that we need to. And you'll see abnormal PT, PTT, and INR. I already mentioned our iron studies. Hepatitis B, you can reactivate dormant hepatitis B with hepatitis C treatment. So knowing what we've got there, hepatitis B core total, also get an IgM of that and your surface antigen. Get a titer on that antigen. If you are negative, you need to vaccinate. Same for hepatitis A. If negative, you need to vaccinate. Consider getting an AFP tumor marker, the alpha fetal protein tumor marker serum lab, just because that's a way to screen for hepatocellular carcinoma, and an abdominal ultrasound because you're looking for abnormal lesions. It also gives you a sense of the architecture of the liver, and then ultrasound elastography. So much easier to say fibroscan than elastography. But basically what you want to do there is just sort of see how spongy, how fibrotic or not fibrotic the liver is with that ultrasound. It's nice to have, it's not a requirement, because we have two labs that we can calculate. When we use our CBC and our CMP, we can get our APRI and FIB4. Those probably stand for words that I can't tell you because you all know how good I am with acronyms. But you can actually determine your fibrosis or likelihood of presence or absence of fibrosis with just simply those two scores, the APRI and the FIB4. But if you have access to it and your patients can afford it, you can also get the FibroScan for the elasticity score. So when you're putting someone on hepatitis C medications, they tend to not interact with too very many meds. There are some definite don't mix these together. PPIs and statins are two, like, just stop those while you have your patient on hepatitis C treatment, because they don't get along well together, and they can have a very negative impact on your ability to effectively treat hepatitis C. But this lovely resource right here shows you all the different medicines that you can use to treat hepatitis C, as well as any other medicine you may have your patient on, and it will give you a recommendation of, this is good, maybe you should consider something else, totally don't do this. So it's a really nice resource when you've got someone on hepatitis C medication. This calculator, the hepatitis C from University of Wisconsin, this is where we do our AST, there it is. APRI stands for AST to platelet ratio index. So you can figure out what kind of fibrosis you may or may not have with your patient. And you can see down at the bottom the interpretation. It tells you, like, when you have a score of this or that, the likelihoods, sensitivity and specificity of whether we're looking at a cirrhotic liver, a fibrotic liver, or a liver that's not yet having these chronic changes related to hepatitis C being present. Helpful links. The AASLD website is fabulous because it's kind of a long summarization, but it summarizes patients. Like, I have a patient with compensated cirrhosis, no cirrhosis, previous treatment, naive to treatment, helping you pick which medications you want to use for your patient. Nice thing about hepatitis C treatment at this point in time, it has gotten a lot simpler than what it used to be. Whenever people tell me hepatitis C treatment is so easy, and then I started doing it and I'm like, this doesn't feel like easy, guys. I have to think about back when treatment was a year long and you had to have a psych eval before they would start you on hepatitis C treatment and make certain that you weren't smoking and your mental health issues were taken care of and you were on medications for them before starting treatment. So compared to that, this is a lot easier, but it's not as easy as PrEP. So the fact that we are providing hepatitis C treatment in our clinic and we have not yet jumped into the pool of PrEP yet, we need to jump in the pool of PrEP. But Epclusa and Mavorite, because again, I'm not going to try and say those generic names. Those are the two main medication and their combo meds that we're using to treat hepatitis C with. But this site can help guide you in those choices. And even though I'm basically arming you with loads of ways that you can learn more about hepatitis C treatment and start to engage in, is this something, do I want to do it? Do I want to explore it? How can I do it? Joining an ECHO, you guys already are ECHO savvy, that's what you're doing right now. But hepatitis C ECHO specifically, and these are just some examples of different ECHOs that are available out there on hepatitis C. But I also highly recommend having a hepatitis C champion, mentor, guide in your back pocket. I've got mine saved in my phone so I can just text him straight away. And say, hey, I've got a patient and I've already done all this work because I know I need to get these labs. Their hepatitis B core is negative. Their APRI score is this. Their FIB4 is that. They can't afford the FibroScan. This is what I think I would like to start with them, get them on Epclusa for 12 weeks. Do you agree, or what suggestions do you have? It also asks on the paperwork for TennCare when we're putting the paperwork through to get patients started on Hep C treatment, what specialist did I talk to? So I have somebody's name to put on that, and I'm not lying. I actually did talk to him. One of the things on the paperwork for Tennessee is they want to know if your patients are still using or not. it is actually not a requirement. We're surprised we're behind on that learning curve in the state of Tennessee and our paperwork. It is not a contraindication to treatment if you have patients who are still using substances. So even if you have someone who's still drinking alcohol, they can be on treatment. If you have someone who is still smoking meth, they can be on treatment for their hepatitis C. Because if you think about it for a minute, if my patient with hepatitis C, active positive viral load, is injecting methamphetamines and sharing a needle with the guy down the road is going to have hepatitis C if he doesn't already. So actually, our patients who are still using really need treatment to help stop the spread. Because again, this talk is about syndemics of how do we slow down the spread of HIV, how do we slow down the spread of hepatitis C. PrEP and treating hepatitis C are the two ways that we make that happen. So never stop learning. 2020, I can't remember if it was 2020 when we started our first patient. If it was the very end of 2020. We may have actually, I think it was this year. So this year, 2021, I started treatment in my very first patient for hepatitis C. I've never treated hepatitis C before. So this year I started. So never stop learning and keep listening to your patients because they want treatment and they're not going to go other places. They're going to come to you because they're comfortable coming to you. So keep learning and learn new tricks and ways to help support your patient and their health and better outcomes. So I just started this year. You can too. Those are some more resources. If this isn't already uploaded to our webpage, it will be. And then I just really love this PowerPoint template because those colors and feathers make me happy. So I'm just going to leave that for a second because it's so pretty. And now I'm going to stop sharing so we can get to any questions you guys may have.
I have a quick question. When you say that TennCare, it would still be recommended for people to be on hepatitis C treatment, even if they're actively using or have used within the last, I think it's 6 months or 12 months or whatever they say on their PA. Are you saying that you've gotten it approved even with somebody using it, or just that they should be on it?
I don't know what we actually
I've never tried. I just looked at the PA and said,
I don't know what we put on our paperwork, to be perfectly honest, because that spot is there.
Mm-hmm.
And we've gotten it approved. And I'm not saying anything else because we're being recorded.
Okay.
Read between the lines, Jack. We actually do what are the current recommendations? I can't help it that Tennessee's paperwork is not up to date. So I'm going with current treatment guidelines, which is if you are currently using, you are still a candidate for hepatitis C treatment. So I'm not going to wait to take care of patients before the state of Tennessee gets appropriate. So any other questions?
What's the recommendation for treatment of the Hep B?
Oh, good Lord, that is a specialist. The recommendation for hepatitis B treatment is to work with your GI specialist. So here in Johnson City, it's Dr. Reddy that we're working with. And that's one of the things we have talked about. If we were to have a patient with hepatitis B, like active hepatitis B, or God forbid, we reactivated someone's dormant hepatitis B, I'd be reaching out to him because that would be a complicated patient that we would need specialty input for. I don't know the med regimens for hepatitis B. Some of the same ones I think that we use for C are involved, but I don't know the regimen for hepatitis B. That's on one of those multiple choice questions, refer to specialist. That's the one to pick. Other questions, guys? Is anybody seeing PrEP prescribed anywhere? Anybody seeing people using PrEP?
I have a patient on it, but only through infectious disease.
Okay. Have you guys talked about it in your clinic as far as like, why aren't we doing this? Have you had that conversation yet?
We have, yeah, and it's recommended. The problem, I think, is that most people that it would be recommended for, at least in this population as far as the IV drug users tend to have pretty poor follow-up. So I think that's a barrier until they're at least a little more stabilized. And then once they're stabilized, they're not candidates as much. So
I don't know how it is in the Tri-Cities, but in Nashville, there's a lot of commercials about it. There's a lot of outreach because there's a PrEP clinic, which also seems to be no charge. I don't know who's funding it too. But they go out to bars and do different things. So we'll advertise that they're doing that.
They go out to bars?
Yeah. It reminds me of the early days of HIV. If you go back to Dr. Verghese's book about the connection in Johnson City and doing testing. And there were actually some funny stories about that too. One of the workers from the Red Cross went in one day and said, "Who's been tested?" You know, and
that's awesome. I like it. Let's go to bars, everybody. I'm ready.
That was the question I was going to ask, just surrounding cost. So, like, working as a sexual assault nurse examiner down in Florida for many years, we did PEP, right? So we were doing a lot of NPEP, which we were generally able to fund through a voucher program. Like, we used Truvada and Tivicay, specifically because they have prescription assistance programs that would cover the cost. But I know if we were dealing with somebody that was, for example, TRICARE, any DOD, like, they would not accept those coupons, as well as Medicaid and Medicare. So the out-of-pocket expense was close to $1,500 for a 30-day supply for one of the medications. So it'd be $3,000 for a month. So that's why I was just wondering, like, if the funding, if that's something that TennCare covers PrEP, or like kind of the costs associated, what you guys were, I know you said you're not doing it currently, but looking at doing it, how that's being worked out.
Do you know, Jack, the patient that you guys have in clinic, what insurance they have? Do you recall?
I do not. I think it's Virginia Medicaid.
So I think, go ahead. Virginia Medicaid.
I think that's what it is.
Okay.
Virginia Medicaid.
So I think this is one of those, like, sometimes when I do lectures, it's like, this is something that you need to do yourself. It's almost like I'm talking to you. I'm talking to you guys, but I'm also talking to you, like, you need to do this, get on the stick. Shame yourself into doing it, because if you're going to educate other people on it, then you should be doing it yourself. So hopefully this is something I can come back and give an update on, like, I know more about it because we're actually doing it. But it's like, let's start asking these questions more. We need to be getting sexual histories from our patients, like number of partners, who are your partners, what kind of risk factors, because with PrEP, I mean, there is that IV drug user piece of it, but there's also just like sexual risk, what's going on there. And then also just knowing that a lot of, and there was a conversation earlier today in our clinic about how are you getting what you're getting, and sexual exchange was not, at least that was the answer today. But, you know, has it been in the past? Could it be in the future? And is that just the answer you're telling me because you don't want to talk about it? So, you know, also knowing that some of our patients will exchange sex for what they're using. We've got risk there that we need to be addressing that currently we aren't. And I almost feel like this is something TennCare covers, but I don't know, because I haven't jumped in that water yet.
Descovy and Truvada they're both on formulary for TennCare.
Yep.
Okay, and I should clarify, with the problem with Florida is that Medicaid, Medicare, they will pay for it, but it requires a PA. In that process, like, if I'm seeing a patient towards the end of 72 hours, it gets hairy. There have been more than once where we just don't get it accomplished. So that's kind of specific, I guess, to PEP, not PrEP, but yeah, good to know.
Yeah, prior authorization is, I should have a slide, prior authorization is a beast in and of itself, like stigma. Prior authorization is a form of stigma, let's just call it. All right, I'm sorry we could continue talking about this, but I want to know about people. What kind of patients have you guys been seeing in clinic? Somebody that comes to mind, somebody that you want to share. And actually, while you're thinking about that, this is an opportunity for me to say, hey, Melissa Hood has joined us. Melissa, if you'd like to unmute and introduce, that would be great.
Hi, I'm Melissa Hood. I'm actually kind of right now educational coordinator and educational planner for this program. I was just recently promoted, and I'll try to be here with you all as much as I can. We also have other conferences at the same time, but I'll definitely try to be here. And then we are also looking forward to potentially an opioid program. So very good to have you all. Just please continue to complete your evaluations at the end of the session, because that's what we use to kind of plan in the future. And then I Am Echo coming up will actually have more credits as well. So that will be something encouraging to have everyone on board for.
Beautiful. Thank you, Melissa. Those are good announcements, and congratulations.
Thank you.
Welcome. All right.
I have one that it's a patient one of my students sees that I supervise that I've been thinking about asking this group for a while. So this is a patient that uses street Suboxone occasionally, and probably doesn't meet for a full-blown opioid use disorder, because it's very like triggered kind of by social circumstances or unavailability of other more desired drugs. And I'm always like kind of in my mind, like, should I encourage this person to go get connected to maybe a Suboxone referral where he actually has his own prescription? Or do we focus more on like, don't do the high risk thing of buying street drugs, and don't let's just decrease the high risk behavior in general, and then maybe this won't be as much of an issue? Or is it better to go a harm reduction standpoint where we know his Suboxone is medical grade and safe, and maybe being on the Suboxone would stabilize some of his other things, which he has some depression type symptomology, difficulty sleeping, a range of kind of just like general like mental health concerns. There's some trauma history as well. And I'm always like, I've not made a decision either way, I guess. And I'm wondering if others have had kind of this experience or thoughts that you might have, particularly from like a prescriber perspective.
Has anyone asked him or her the DSM-5 criteria?
More or less, yes. So there's not tolerance, and there's only the withdrawal isn't when it's happening pretty regularly. He'll withdraw, but then he does come off of it, and then he's fine for a while, and he doesn't ever really crave. It's more like a situational thing. So I don't think he would meet, maybe for mild, but probably not for kind of the threshold that we would usually be seeing, or we would be starting to prescribe.
My question would be, what is the drug of choice?
Usually, again, I think this is a little bit situational, but it's usually alcohol.
Okay.
But sometimes marijuana and sometimes meth. But yeah, I think mostly alcohol.
Because the treatment is certainly required for the substance use. The referral to the substance use treatment would be appropriate at this point, not just the Suboxone or opioid treatment. And the problem is right now when the alcohol is readily available. So what is the reason that he is going to the street and buy the buprenorphine? Is it the intention of the not drinking, or the drinking is the dangerous medically and he's worried about it, and now he's trying to switch it to something else? So those are the questions that I would try to figure it out, that why he is substituting, the drug of choice, which is readily available, is legally, available to him, and going to the street and buying something that may put him on a dangerous situation.
doesn't have super great insight into like that. I don't have a really great story on that. It seems to be more like, yeah, like people have it for him to take, and then he'll switch to that instead. And he does like it. So he's not interested in substance use treatment per se. This would be more of a like harm reduction kind of, like you have medical Suboxone instead of who knows what Suboxone.
Because I think that it was for a long period of time, people have this notion of if it comes from the pharmaceutical, it's safe to use it from the street, which is not. I mean, we know that it's not. And that's one of the, downfall of when the people start using the pills from the street. They give themselves this false assurance that it's safe. And of course, buprenorphine does not supposed to cause any kind of the high for people to get that different feeling from the physical effect of the buprenorphine. But mentally, I mean, you can have a placebo effect of buying something that is controlled substance and use it and get high mentally from it. So that's lots of, I think, pre-contemplation state that needs to be worked up on this point, and some motivational interviewing, and that would be my suggestion on this case. But certainly the buprenorphine would not, it does, I mean, in fact, Dr. Geller is here and he can give us I don't know if we brought up this case that we had one case actually that the patient was using the buprenorphine and came here to get off of the buprenorphine, very small dose. But it was interesting, the day that he was reducing the dose, his alcohol was going up. And Dr. Geller gave the patient, kind of the schedule to find out how much of the alcohol and what day he's using. It was clearly any day that he was using 2 milligrams, he was doubling up in his alcohol. Even though these two substances, they are not supposed to help each other, but that was the kind of the behavior that we noticed. And as soon as he started taking a buprenorphine regularly in 4 milligrams every day, he was able to limit his alcohol and make it the same amount of the alcohol every day, but a smaller dose. So that was one experience we had, that Dr. Geller and I, we were involved in the treatment. And so even though there is from the evidence base, we don't have treatment of the alcohol with the buprenorphine. But in reality, sometimes we see the cases.
Meredith, how is he doing? Like, is he coming consistently for his appointments with you guys?
This is also, there's insecure housing. So there's just like a lot of general instability, but for someone from the kind of that population, yes, he's definitely pretty consistent and engaged.
Okay. And do you see that there have been any changes? Is just him holding steady in and of itself progress, because he's not falling down further? Just maintaining right now is a goal.
I think that's sort of where we're at. We've set some more aspirational goals at times, but the being steady and being a little slower to jump to high risk behavior. Waiting a few hours in the day is sort of kind of where we're at right now. Yeah, it's very much like a harm reduction.
Other than substance use, are there other high risk behaviors?
Like driving without a license, and there's things that could get him in significant trouble, for sure.
Okay. Well, it's good that he's coming back as much as he can get back.
Yes, for sure. Yeah, the students done a really good job building like a non-judgmental, positive regard kind of a situation for sure.
Because that may be the place where you're at is just, I've been in so many different talks lately, I can't even tell you. And one of them was with Skylar. I think it was the MAT half and half we did, where he was talking to the group about outcomes. And outcome number one is, and like ask the audience, what is your outcome? And he's like, the second appointment. Came for one, really working hard to get him to come for number two. So it's the fact that he's coming, that is progress, and inching him toward a place where maybe being more receptive to the idea of intervention for his use. And since we're in the same neck of the woods, I'd love to help him out. So.
And we always remember that the naltrexone was first, approved for the alcohol use, and later on becomes the opioid use treatment as well. So maybe in the future they come with some study, and that shows maybe the buprenorphine is also giving it does work on the mu receptors, and the reward system is pretty much related to that. It may, affect that one as well. Is he open to the idea of the using naltrexone for the sake of the, reducing the craving for the alcohol, or?
We've gotten really close a couple times, but it's never happened. But yes, that is a conversation we have had. But that's where that I'm wondering is, would the buprenorphine be an easier in? I don't know.
Yeah, and that would really eliminate the effect of the buprenorphine, or false effect of the buprenorphine, if he gets educated about the naltrexone. It's not a bad idea for him to see a prescriber if he's interested in general, and highlighting the alcohol use or giving the patient at least opportunity to see it from a different view may come handy. The same thing again, the same patient that I just described, he didn't know that he does have alcohol problem. After he recognized the pattern of his alcohol use, he just recognized that one and started, working on it. He was purely here to get off of the buprenorphine, that's all. His first intention of the coming to the clinic was that, but then when we were able to show him what was the pattern of his alcohol use and how it was related to his buprenorphine, he recognized that his main problem is alcohol, and buprenorphine is just that, maybe a subside of that problem. So I think that would be a good idea if he's interested in getting a treatment, to see a prescriber later on when he's a little bit more motivated.
Following our chat a little bit, Michael just shared, apparently I've not clicked on it, but I will click on it, musiccityprep.org. Skylar's had a chance to look at it and has given it his endorsement. So we'll all need to check that out. And
Joyce, I have to add that I've seen the commercial so many times that when you start talking, it said prep, the electronic music that plays throughout the commercials started to play as an earworm.
That's awesome. They've got some good marketing, don't they?
Yeah, they're pretty slick. And it turns out that I didn't know that a former colleague at the Department of Mental Health here was actually one of the founders. I didn't know that until I looked at the website.
So everybody open your chat box and pull that link out and go visit it. And Rick is filling the chat box with really wonderful resources. So copy all of those down as well, because that's what Rick is constantly doing in the background, is churning articles that he has searched and found that's related to our conversations and topics. Depression and sexual risk behavior, syndemic among early pre-exposure prophylaxis adopters in Belgium. Syndemic incorporating opioid overdose management into routine care for people who inject drugs, initiating Hep C treatment. So there's loads of lovely things in there, in addition to a fun website we can visit, thanks to Michael. So visit that chat box, definitely. And it's just, it's one of those things sometimes, like you raise up your head and it's like, where have I been and why am I not on this bandwagon? Like PrEP is happening. Are we? So getting involved in that, I want to go Google the commercials now too, so I can have that same earworm, Michael. But I think Meredith's case is actually, it's a very important case because this is a gentleman who is engaging in some type of intervention. It's not prescription at this point. It's not medical at this point. This may be someone who actually finds their way through their substance use habits in a way that doesn't require prescribing, or he may need that. So there are lots of different places, levels, and ways in which individuals who do have substance use disorder, because it sounds like probably, if not for opioids, maybe for alcohol, we could come in with a moderate, severe use disorder for that. Sounds like there's co-occurrences, depression is part of that picture as well. That, you know, he may be able to find his way on a recovery path that's of his own making, thanks to the work that they're doing in the counseling center where Meredith works with her students. So that's part of why this community that we come together and share with one another on ECHO is so important, because at the end of the day, it's about getting our patients connected to a healthier lifestyle, whether that's in my office, your office, Meredith's counseling clinic, an AA meeting, somebody that you just know and are friendly with. It's really about those connections that get made in the way in which we support the people we encounter. We get together again. We're starting to wind down. Maybe that's part of our attendance today, because I think the semester has ended. So I think that might be why we aren't seeing our good friends from the nurse practitioner program, because the semester's over and they're all at the beach. Everybody's going to the beach right now. I can't tell you how many beach plans I've heard about today in clinic. Like, I don't have any. Something's wrong with this picture. But hopefully when we get together again in 2 weeks, we see more shining faces along with your shining faces again. But we will get together again in 2 weeks. And I think that's June 9th. Yes, it is June 9th, because I've got 2 patients from today coming back in 2 weeks because they're going to the beach next week. So we'll see you guys on June 9th when we have a wonderful topic on criminal justice stigma from one of our other psychology colleagues, Kelly Moore. She'll be joining us to give us that talk. And I'm going to have to get a little more serious about beating my drum for cases. Thank you, Meredith, for your impromptu ad hoc case presentation. Very much appreciated. But let's get some cases next week. Next week. Yeah, I want them next week. I don't even wait 2 weeks for them. Let's get them next week. So we've got those in the pipeline. We can share them and talk about them when we get together on June 9th. Does anybody have any other announcements? We've had the wonderful promotion of Melissa Hood. Anybody else with announcements before we sign off? Anybody else going to the beach? Okay, all right, we're all here together. I like it. All right, you guys, we'll see you in 2 weeks. Take care. Be safe out there.